Thank you very much for the organizers to invite me. I'm one of the surgeons at WashU Barnes-Jewish Hospital. I lead our ECMO program as well, and it is a delight to be here amongst all of the colleagues and leaders, both institutional, national, in cardiology. I've read a lot of your papers. I think I learned most about VT that I've ever learned ever. So that was great. I'm going to start. Should we implant durable LVADs in the patient support with percutaneous MCS in the era of new allocation system? The focus is on new, so we'll learn a little bit about old. I took a lot of old slides out because of the time limits. So the National Organ Procurement Act was initiated in 1984 that gave birth to OPTN and OPOs. Initially, a two-tiered heart allocation system was initiated in 1988, and 10 years later, a three-tiered system was created in 1998. In November 2005, broader sharing of donor hearts was initiated. And in this paper, they mentioned three eras. One era is from 03 to 06, then 06 to 09, and 09 to 013. And if you look at the line that says 1A and 1B, in every era, with the different allocation systems, stage 1A and stage 1B heart transplant waitlist patients enjoyed better survival. Their mortality decreased. This was the old allocation system. This was replaced by the new system in October 2018. So I thought I should mention something about the old allocation system. If you look at it, stage 1A patients are the patients who would have VA ECMO, intra-aortic balloon pump, total artificial heart, or inotropes and a Swan-Ganz catheter. All these patients were lumped into 1A. They will be found in your CCU. In the hospitals in your zip codes, and these will be the patients who will be competing for the organ. The second group of the patients is 1B patients. These are the stable VAD patients or the patients on inotropes without any Swan-Ganz catheter. If you look at 1A, you could see how different the patient physiology and pathology is and what type of different devices they are in, and they're competing for the same organ. This is a region in the United States. Whoever belongs to whichever state can pick out their region. I am in the state of Missouri, so my region's 8. These are the patients who are on waitlist based on the old system. So the bottom is blue, which is status 1A patients. The middle green is status 1B patients, and the top tier is and the top level is the status 2 patients. You could see the funnel that is increasing from left to right. And that is a funnel that is of stable LVAD patients. These are the status 1B patients. And you look at this slide, in the x-axis are plotted regions. Let's, for example, take region 9, which is on the northeast corner of the United States, and you would see the blue bar is really high in the station in the region 9, because those are the patients who would get transplanted in status 1A. If you look at the bar next to it, which is region 8, which is my region, status 1A transplants are much less than status 1B transplant. That means the sickest patients are not getting transplanted in my region. Hence, status 1A candidates are 3 times more likely to die on the wait list based on the old system. Increased use of mechanical circular support and associated complications were not addressed appropriately. And these organs were not shared appropriately because hearts would be offered to the local recipient first, and then to the distant recipient, whereas the distant recipient may be on ECMO, and the local recipient may be at home on inotropes. Therefore, the UNOS Heart Subcommittee was tasked to change the system, and they had a few options. Either they could leave it as is, or the second point, alter the 3-tiered system by changing the qualifying criteria for each status, or they could expand the number of tiers. That's what they ended up doing. Or they could develop a formal heart allocation score. But the problem was they said it would take too long to develop, and it would be difficult in the times of rapidly changing heart support technology. And you saw all the letters and alphabets that are now used to denote the type of therapies that we can provide. So it was hard for us to develop the heart allocation system, and I use us with care. These investigators from Cedars-Sinai then said, and I quote, "With the rapidly evolving options for mechanical circular support, i.e. ambulatory ECMO and Impella, we envisage that the future therapies will blur the distinction between temporary and durable mechanical circular support devices." French were battling the same thing. They came out with their new allocation score in January 2018, and they wrote this paper about it. They developed a candidate risk score. They developed exemptions to the candidate risk score. They also included other criteria besides the blood type into their matching. And they also took into account the time it would take to go from place A to place B to get the heart. Hence, we then created in October 2018 the new allocation system. This is the playbook by which I play with and my other heart failure colleagues play with these days. Status 1 patients are the sickest. These are patients who are on VA ECMO. Status 2 patients, I'm going to highlight the patients we deal with on a day-to-day basis. Status 2 patients are the patients who either are on Impella, balloon pump, Swan-Ganz catheter and inotropes, or they have a mechanical, or mechanical complication of LVAD. Status 3 are the patients who are on inotropes and Swan-Ganz catheter, and status 4 are the patients who are stable LVAD, and that status 4 patient is still not enjoying what they should enjoy with the new allocation score, and I'll show you why. This is a report that came out hot off the press 2 weeks ago. I got my hands on it last week. This is the OPTN report that now has evaluated the change in the allocation score over the last year. As you could see on your, I'm a lefty, so I have to be careful. As you can see on the bar on your right, the status 1A patient, the status 1 patient and status 2, the dark blue and the light blue, they have seen an exponentially and dramatic increase in the transplant. The green bar, stable VAD, are still waiting to get transplanted. The center-specific transplant volume depends on the waitlist composition of the transplant center. So as I stand right now, WashU Barnes has 3 patients, status 1, admitted in the ICU, and rest of them all are not status 1 patients. OPTN report also suggested the use of ECMO, balloon pump, Impella, all was higher after the allocation change in the new era. Most interestingly, the LVAD implantations have gone down significantly in the new era. It used to be close to 80%, now it's down to 60%. LVAD volume nationwide have gone down. Does that affect survival? Because the allocation was changed about a year ago, so the data is only 6 months long. So there's no difference in survival between the graft. There's no survival difference of the patient. However, it took us longer. The ischemic time is higher. And as I mentioned, French took into account the ischemic time that it would take in the allocation score. We did not. So it is taking nowadays longer time to get the heart and put it in. But this is the cool part about the new allocation system, that the blue bar is the pre-era and the green bar is the post-era. And as you can see, now there's a little bit more equitable sharing of organs across the region. So I can go, and I have gone, not me, I have a procurement surgeon, but my procurement surgeon has gone down to Dallas and as close to Austin to get the heart for my recipient, whereas in the past, I don't think I could go any south than Dallas. So it has allowed us to get more organs, but now it has come at a price of higher ischemic time. So then I come to the meat of my talk, and I developed 10 questions for these talk. These are the patients who are on percutaneous support, either going to VAD and then transplant, which is the title of the talk, or percutaneous therapy and straight to transplant. What factors would affect physician and patients to stay on percutaneous MCS or move on to VAD? I would say patients should stay on MCS if they are ambulatory percutaneous support, they have severe biventricular failure, they're stable patients, their device is stable, not causing hemolysis, malposition, and ischemia of the limbs. The percutaneous therapy has halted the end organ damage, the blood type is favorable, and the transplant center is awaiting the best organ. For example, organs are offered and they're declined, and you are waiting for the best offer as opposed to a recipient who's so sensitized that he's not even getting an offer. Or the patients who are getting dual organ transplant. If these factors are present, we can hypothesize that these patients will get transplanted early, but the current data that we have does not suggest it right now. So, what is the waitlist time? If I have a patient on percutaneous therapy and I said, okay, I'm going to VAD this patient and then transplant him, guess what? With the new OPTN report, that patient may not get transplanted. He would be on the waitlist for a long time, and that is still a problem in the current waitlist. So I'm not comfortable in switching my patient from percutaneous therapy to VAD therapy. This talk would be a completely different talk if I were giving it in 2017. Can a percutaneous cardiac support patient can even get to durable VAD. This data was put out by my friend from Iowa and my previous mentor from Michigan, Frank Pagani. They looked at in the top square, they looked at the patient who had durable LVADs, and then they backtracked it, to the patient who initiated as ECMO, tandem heart, or went direct to transplant. And then they showed that the worst survival was patient who went from ECMO to VAD. The second worst survival was the patient who went tandem to VAD. And the best amongst the three were the patients who went straight to VAD with a balloon pump intermax level 1. What has less adverse event burden? What has less adverse event burden? And that depends upon what type of therapy we're talking about. VAD are still marred with a bunch of complications, so is Impella. Does Impella 5.0 strategy as a bridge to transplant affect the death on waitlist? This is a paper presented from University of Pittsburgh, my former institute. They had 236 patients on Impella 5.0 inserted via axillary artery as a bridge to transplant, and only 24% patient got transplanted. 75% were removed from the wait list, either went to continuous flow LVAD or died. If you put on patients on ECMO, can they go on to transplant? This is French registry, and they showed ECMO has early death and also has lower survival after ECMO. What is more cost-effective? The group from Taiwan and Korea have said in the red bar that the direct that kind of feels like rodeo right now. Oh, it's in time. Okay. So the question is, now we have a 64-year-old patient who has biventricular shock, has gone on an ECPella. Should he get transplanted or should he get VAD? The other person is a 30-year-old male patient. We don't know him. He is a smoker, and he's on ECPella again, Impella and ECMO. Should he get transplanted or should he get VAD? And these are the type of questions we're still discussing, especially when patients go to VAD. I'd like to thank the opportunity to the organizers and the team in Houston to having me over and presenting my slides, and I welcome questions.